Lung cancer has always been stigmatized as a smoker's cancer, and now we're seeing that this is really not correct. Many patients, the patients we're going to talk to in this program, were not smokers. And they were subjected to environmental pollutants or to environmental hazards that are unbeknownst to us. So clearly that stigma needs to be broken.
I was just in such shock. I kept expecting to wake up from a dream, and have it have been a nightmare.
Many times we're dealing with lung or esophageal cancer, and everybody knows these are very bad cancers to endure.
With lung cancer, there's just always been a stigma attached that, oh, lung cancer, oh, they must have smoked, but that's just not the case.
The non-smoking female is at the highest incidence of developing lung cancer than we've ever seen before.
Even patients my own age, patients in their 40s with lung cancer that have never smoked. So it's not just a smoking disease.
Today is our office day, and we see new consults. Many of them are follow-ups. Many of them are new patients. The majority are cancer patients. So we need to get a CAT scan.
Yes.
So let me do that, and then you're going to come back and see me again. For breast cancer, for colon cancer, we've already made a dramatic impact in screening methodology and also in survival. Did you have any symptoms?
At all.
Nothing.
None.
Right.
None.
One of the ways that we can increase the ability to catch patients at an earlier stage for lung cancer would be to screen them appropriately using national guidelines. Also to work with their primary care providers to really help identify these patients. Patients that have had exposures, patients who have emphysema, patients who have high-risk professions, firefighters, etc. The good news is that this form of radiation will give you a very good chance at cure for the lung cancer.
Think so?
I don't think so, I know so. So the majority of cases, unfortunately, are found incidentally for women with lung cancer. That means they've had a shoulder pain, or maybe they broke their leg, or they came in with a random chest pain. And so patients are given randomly a chest x-ray or a CAT scan, and then they're found incidentally. But thanks to the random finding, we've essentially given them the best chance of cure because we're catching the lung cancer early.
Come here. What? What? You want the ball? Do you want the ball? Yes? The only thing I can think of, the only reason that my shoulder would be hurting is because I play tug of war. We have a golden retriever, and I play tug of war with her. And in July, at one point in time, she really just really slung her head, and it really pulled my arm. So I think that's probably what hurt my shoulder. So I went and I got an MRI, and the MRI came back Thursday, and Friday morning I got a phone call from his nurse. And he got me in there and he said that, yeah, I had a slap tear of my shoulder. But the big news was that they'd found a shadow in my lung. My husband and I are freaking out. And we have 2 kids and who are in high school. And we were just in such shock. I don't smoke, never smoked, eat organically, lead an active life. I was a vegetarian for 7 years. Everybody was saying, why you? This is crazy.
I kind of made my own diagnosis, and it came out of nowhere. Really healthy. I never smoked a cigarette in my life. I started having a cough without a preceding cold, and I thought, okay, it's unusual. And then one day in the studio where I work downtown, I tasted some metallic taste in my mouth after I coughed, and I forced the cough a little bit, And indeed, it was blood. Got the chest x-ray and I asked to see it, and I saw the lesion. It was one single big lesion, 4.5 centimeters. And even the radiologist was kind of, geez, you don't see that very often. And he looked at me, you're not a smoker, are you? No. And he goes, well, it's probably not lung cancer. It could be this, this, or this. And so you start praying for all the alternative diagnoses, and it was none of those things. You know, it was lung cancer. In my case, it could be from the pastel dust. I did not wear a protective mask. Most professional artists are not wearing protective masks. I also believe that my exposure to secondhand smoke is probably more likely. My father was a smoker, quit when I was about 14 years old, ahead of his time. I also had breast cancer at age 38, completely unrelated to the lung cancer. And it's much more acceptable to say you've had breast cancer and have survived that. You have pink everywhere. But the fact is, more women die of lung cancer than they do of breast cancer.
I think that the fact that you are a 1A lung cancer means we're pretty much fine. I mean, every breath we take, we're exposed to a substance that potentially can cause cancer. And depending on our predisposition to developing it, we're lucky or not. It's still the #1 cancer to die from should you get it, compared to any other cancer. So I think now more than ever, we're focusing on changing our bad results over the last 50 years for lung cancer. We offer a very multidisciplinary approach for lung cancer surgery. We do minimally invasive surgery, whether with video-assisted approach or robotic. We also do classic lung surgery, which is the larger incisions for bigger tumors. We also do stereotactic radiotherapy, which is the new form of radiation to treat and potentially cure lung cancer. So at this time, we are really employing every sophisticated means, including lung cancer screening. We also have different therapeutic interventions, such as surgery and also specialized radiation therapy, to kill and potentially cure lung cancer. So we have other options that can cure a patient with early lung cancer. So all of this adds up to a better outcome for the patient. We've proven most recently, especially, that if we catch it early, the survival can be greater than 80%, even 90% or higher. Let's talk about what's going on. So when you presented to me, you had basically a lung mass that was seen on CAT scan and on PET scan. Mm-hmm. Linda is not unique in a sense that her case is like many women who have lung masses who now are undergoing a workup. That's what makes this so interesting to me. Now, the fact that you're really not a smoker, the fact that you really don't have emphysema, the fact that you may have lung cancer, and also that you and other women who are non-smokers are now at one of the highest increases or incidences of getting lung cancer. In her case, we still are not convinced she has lung cancer, but at this point we're left with only a surgical means for diagnosis and treatment all at the same time. The procedure that we plan tomorrow is the most common chest surgery right now in the world, and that's called video-assisted thoracic surgery. Our plan now is to go in with small incisions with a camera, evaluate the lung, biopsy the lung, take out the portion of lung that is of concern, and then essentially diagnose her and treat her lung cancer all in one sitting. I'm siding with it not being lung cancer.
Okay.
All right?
That'll be great.
This is your new image, and that's what we're going to base everything on
and
tomorrow.
where is it exactly?
Right upper lobe, where it was before, just on the right lung, in the upper lobe.
Point it.
Right there. That's it right there. Right there. Giving hope to patients is the most important thing we do as physicians. It's a realistic hope. It's a hope that a lot of times is bounded by fighting and being strong. But a physician that doesn't give hope is not a physician. So today we're actually going to obviously put the patient to sleep. We'll look inside the lung with what's called a bronchoscopy. That enables us to look in the airways of the lung. And then,
Excuse me for a moment. Bovino has a small to moderate left pneumo.
that's fine.
It's okay. All right.
She's come to me in the setting of being told that most likely this is lung cancer, which is not uncommon. Many patients have a lung mass. Physicians are concerned, and many times rightly so, that it's a lung cancer, and that's why they come to me for my evaluation recommendations and then to sort of fix the problem. So we'll do our bronchoscopy first, guys. Look inside the lung. Although we do behave in a relaxed manner, we're always sort of on the tips of our toes because these are high-risk cases. Chest surgery is always considered a technically demanding surgery. This is our lung isolation. That's the tube. These are double lumen tubes. So this tube goes to the right lung, and then the other tube you can't see goes to the left lung. So you're able to control each lung by clamping each tube. So you can drop one lung or the other. I'm just saying sort of my first impressions. But usually lung cancer is an isolated area. You know, maybe some of it is stuck to the chest wall, but it's isolated. We're seeing sort of inflammation throughout the entire lung.
So is that good news?
And it could be very good news, yeah. But the story's still continuing. This is all scar, so we're gonna have to take that scar down. Can we get that harmonic scalpel open again, guys?
And look in different areas.
There you go. You see, that's what's going on.
Yeah.
So this is not really different from any lung cancer surgery. I mean, we're just taking down adhesions here. We have the lung there. We use the same techniques, video-assisted thoracic surgery, just like this. We're working over the tops of the ribs. John, can you give me, rotate towards me a little better, please? That's good. For chest surgery, right now, across the board, most chest surgeons really rely on their, tactile sense, the ability to feel their hands, how hard I'm pulling on this lung. This usually was done with an open approach, meaning a big thoracotomy, incision. Patients had more pain. Go home later, This is really modern day surgery. It's just minimally invasive, using your hands. The lesion that we showed you guys in the CAT scan, the mass, I think we're seeing it now. That area there. Hold this, Scotty. It's exactly here. This is the area that there's been concern about.
You see some discoloration in the tissue compared to the surrounding. Some of that scar, but there's also
See that?
underneath there. You see the change in the color here.
That's what set off the whole lung cancer alert for her. That's really it, man. That is really it right there. Yeah, that's the only lesion in the lung right there. So if we take it, let's just see what we can do.
These devices are used in a lot of different areas for different
Show it up
things.
closer. This is what we use. We've been using this for many, many years. Very reliable. It literally cuts and staples the lung. Leaves 3 rows of staples on the patient side, and on the specimen side, cuts in between. You don't want to deal with any bleeding. So these things are so reliable. And then, of course, the lung is filled with air. You don't want to deal with a chronic air leak. That keeps the patients in the hospital longer. We rarely see that now. Well, she had a cavitated lesion. Yes, it was an SUV of 5. They put a needle in it. They only found granulomata. Okay? She's a non-smoker, but there was concern by multiple physicians that this was a lung cancer. So we did a
Smoker, you said?
non-smoker.
Yeah, I see what you're saying. You're right.
Yeah, well, we'll see what it is.
Yeah.
She has the specimen, the right upper lobe wedge. We're gonna slice it, freeze it, and do what's called a frozen section so she can see it, or the pathologist can see it underneath the microscope.
And what will that tell you?
Well, that'll tell us really right now. We just want to know, is it cancer or not? That's the bottom line right now. Now she's going to put some of that tissue, the suspect tissue, on a slide and look at it underneath the microscope just to see quickly what it is. Again, if we're not seeing cancer and we're seeing abscess, then we have our diagnosis and we've sort of proven it now 100% to her. If it's cancer, I need to know now.
Okay.
But you're not seeing that. You should.
I'm not seeing any definite, of
Yeah.
course. I mean, these are not foolproof, as you know.
Well, why don't we give you some time and I'll come back. Although we've done lung cancers and other tumors that go home the same day. But in her case, I probably would keep her here one night. The reason is because we broke up all the scars so aggressively. That's a fairly aggressive operation. So basically, we're finding evidence of infection, likely from aspiration pneumonia. So really, we've helped diagnose her whole disease process, which she has a paraesophageal hernia. She's aspirating. So it's not cancer.
That's good news.
So that's great news. So let's go tell the OR the good news, and then we have to start closing. So no evidence of lung cancer. She's got aspiration pneumonia. Anyways, I'm going to scrub. Hi there, family for Solis. Are you all here? Good. So it's really great news. We did not find any cancer. It's a lung abscess. We know what she's got, and now she's going to get better. She'll probably go home tomorrow. I have a lot of good news for you. First of all, the chest tube came out and you're feeling well, right?
Yeah.
We see this very commonly, this case, where someone comes to us very scared and then we work it up in a very safe way, many times minimizing the pain. We're able to definitively close the story and the patient's very happy. And this is a classic case of that.
They all seem so certain. I went to 3 different doctors and they all came up with the same conclusion except for this one. You know, so what the heck do I know? If they say you have it and you take all the necessary tests, you assume you do?
I want to see you in my office. Let's have her come back tomorrow.
Okay.
Before the weekend. Is that okay? Just for a chest x-ray and all that. It's exciting what I do. It's gratifying. I love operating. That's probably the most enjoyable part of what I do. And then, of course, being able to change, make a difference in someone's life very quickly, very acutely. It's unlike anything else in medicine. Of my 4 uncles, 2 of them died of lung cancer. And both were non-smokers. I could remember my father looking at Nino, his brother, and telling him that there was nothing else to do. And the complete lack of hope in his face, I could never forget as a kid. I think with lung cancer, what we want to change is the attitude in the community and beyond that it's something that's not curable, that we have no control over it, that it's sort of a definitive, chaotic endpoint, when really we do have the ability to catch it early, cure it in many circumstances, treat it very humanely with minimally invasive surgical techniques, causing minimal damage, morbidity, and pain. My father's history and past, I think, was passed down to me in the desire to try to make a difference, to try to impose a meaning or a meaningful nature to the universe. Once again, fighting chaos. And that really translates for me in 2 ways: in fighting disease as a doctor, and then also in the exploration really of art and music, which I think run very much parallel. I think in knowing Terry and knowing a lot of my patients, I think that sense of fighting the futures, sort of the problems that are created with cancer and disease, that sense of the fight and the desire to overcome is very important. When Terry was diagnosed with lung cancer, she painted this fairly dramatic piece that is very emotional, very mystical, and somewhat despondent.
They say a lot of it is your attitude. 90% of it really is attitude, and I was just determined that that I was going to be here and continue to be here for them.
So how have you been?
I've been okay. I've been doing really good.
How's it being back at work? I'm an oncology nurse navigator based at Mercy San Juan, but work for Dignity Health. And my role is to navigate cancer patients from as early as diagnosis as possible and help them support and guide them through their cancer journey. So no more side effects from the chemotherapy, you feel it's...
No, I really am feeling good, really good physically. That afternoon I got a phone call from a woman. And she said, "Hi, my name is Rachel McConaughey, and I'm a nurse navigator. And well, first of all, do you know why I'm calling you?"
The day that I connected with her, I think I felt relief in her voice. She knew she had an advocate and a supporter to help her through this journey.
She so understands just how people need to be taken care of when they are so traumatized.
The great thing is with research, and every year there are advancements in treatment for cancer, and I'm even seeing that over the last couple of years, new drugs, new procedures in the OR. So I see more people cured and doing well after treatment than going the other way.
My idea about lung cancer was that there were very specific things. Obviously smoking's the big one, is the real big one. But, other than that, there was a very specific reason that you got lung cancer.
I mean, I think you always live with the diagnosis of cancer. Once you hear that word, your life is changed forever. But to see people come back, especially Deborah today, it's a year. It's just a great feeling. I'm just so blessed to have met her, and I feel very connected with her and her husband. And
you wake up every day, and I don't know, you might ask my kids, but I think I yell at them a little less. I'm a little faster to look for funner things to do and not, not postponing fun.
Get to go on living with a little bit of a change in attitude that every day is precious. This is my husband and I on top of Taft Point, and this was 12 days after my first surgery to remove my lung cancer. We do an annual anniversary up there. We renew our vows at Taft Point across from El Capitan, and I was proud that I could do that after surgery to prove that even with the loss of lung there, I could still hike, because hiking is very important to me. I think more about other people. I think about my friend Patty, who didn't make it, and we shared many walks along the river. And the conversations we would have, she was only 49 years old, still had a son in elementary school, and she died of her cancer. My mission has been to destigmatize lung cancer. I feel strongly that people need to know that anybody can get lung cancer. Non-smokers, it's increased incidence for women particularly, and young women. We don't know why. We no longer should think of lung cancer as being self-induced by people who have done this to themselves. That I hate when I tell people, you have lung cancer. I had lung cancer. They're saying, did you smoke? And so now I preface it, I have non-smoker lung cancer, and that it's important.
It really is very scary because it could happen to anybody.
Ask your primary care provider, should I get screened for lung cancer? Should I have some workup for it? Am I at risk? What should I do? Be very instrumental in working with your primary care provider to see if you have a cough, for example, or if you have symptoms, coughing up phlegm or having emphysema or being diagnosed with emphysema, should you get worked up for lung cancer?
And if you look at the statistics, you know, the statistics for lung cancer are really, really bad. And there just doesn't seem to be an awareness of it out there.
You know, breast, you get mammograms. Colon, you get colonoscopy, which for lung, currently, there's really nothing.
I think that part of the reason that you really have such a good chance of living with breast cancer now is because of the awareness and the fact that it's been going on and the research has been going on for so long.
Right now, I think for the first time in history, in world history really, lung cancer now has a big movement for screening, for catching it early, and then for treatment. And we will see over the next few years that survival will dramatically improve.
Listen to your kids if they tell you, Mom, you know, that cough's gone on too long, or what's that cough about? Listen to that. You know, most people do know their own bodies, and the sooner you pick up on something like that, you know, the better off you'll be.
I think it's just being aware of symptoms that they may have, just being mindful of your health, and if there is something going on, to pursue it.
It's not just about being alive, it's about fighting for the things that count to you. And I think that more and more we focus on that for patients.